1 second. Welcome everyone to our bi-monthly spinal cord injury in-service educational topics. This month, Dr. Mackenzie McDaniel will be talking about nutrition and metabolic changes after spinal cord injury, which is definitely a big topic for anyone to undertake. So I appreciate Mackie going for it. As always, if anyone wants to review these lectures, they will be on the YouTube channel. Mackie, go ahead.
All right, thank you. So like you said, I'm going to talk about nutrition and the metabolic changes after a spinal cord injury today. Basically post spinal cord injury, there are a lot of health considerations. So individuals with spinal cord injury are now living longer thanks to advances in medicine, insights into best how to manage their post-injury health care, and increased opportunities for them to have independent lifestyles. But along with this increased lifespan and increased opportunities are increased risk for metabolic diseases. So obesity, dyslipidemias, cardiovascular disease, insulin resistance, things like this. And so there's a need for specific nutritional recommendations to prevent obesity and therefore lower the risk of these metabolic syndromes that are specific to those that have had spinal cord injury. And this was a good graphic I found that I really liked how this demonstrated kind of the input versus output and the balancing act that goes into this. So you have an individual that's got a spinal cord injury. You have a low energy expenditure and then a high caloric intake, and you can see how this would tip the scales in the wrong direction. When you have an SCI, you have a decreased expenditure due to loss of lean mass, increased the fat mass, endocrine changes, sympathetic changes, activity level decrease. And then on the flip side, you have potentially an unhealthy diet, depending on who the individual is and what they intake. But also we have a whole array of dietary guidelines to look at, and not necessarily many of them are geared specifically toward those that have had an injury. And we can see how we can use these dietary guidelines and activity guidelines to help better balance the scale and prevent some of these diseases. So some factors just affecting the energy requirements. At baseline, even for the individuals without injury, basal metabolic rate is influenced by many factors. You've got your fat-free mass, your lean mass, your muscle fiber type. They're throwing back to step one in medical school here. You've got your myosin light chain and myosin heavy chain isoforms that determine the cross-bridge cycling, which is basically just the type of muscle fiber. So type 1 being slowest, type 2 being faster, and just the type of muscle can affect the basal burn. And then you've got sympathetic innervation, age, and gender. These all have a influence on the energy requirements for these individuals. So research is currently being done to determine an equation that would better allow us to predict the effect of this spinal cord injury on individuals, so we can better determine what kind of energy requirements that they need. And to just go over some vocabulary here so we know what we're talking about. TDEE is our total daily energy expenditure, and it's made up of our REE, which is basically your BMR, which is your basal metabolic rate, and the rest of it is all made up from the non-resting energy expenditure. And this is what's called your NEAT, so non-exercise activity. So this is you're fidgeting around, that sort of thing. Your movements that are not purposeful exercise. Then your thermic effect of food, and which is the kind of the heat and the energy that's required to burn to digest your food. And then you have your exercise activity, which is your purposeful movement. And these two in combination create your total daily output. So BMR typically, so your basal metabolic rate, typically accounts for about 60 to 70% of the daily expenditure of individuals that have a spinal cord injury. So if we go back to that last slide and we look at our graphic, so the bottom area where it's got the resting energy expenditure, that is typically about 60 to 70% in those individuals. without a spinal cord injury. But if you look at individuals that do have a spinal cord injury, it's 80%. So this loss of metabolically active tissue is causing the total daily, the BMR to account for a higher amount of their total daily energy expenditure, because they're not having as much of this expenditure from other areas. So to estimate the energy requirements, the most accurate way of determining the metabolic needs of an individual, both those with injury and without, is going to be a lab-based testing. So you have indirect telemetry, testing in chambers, double-labeled water methods, basically all of these things that are not reasonable to try in a large population, and it would not be accessible to many people. So for those that don't have any kind of injury, we've adapted this equation called the Harris-Benedict equation that can give us a fairly rough estimate of what they should be consuming within a day to maintain energy balance. However, this obviously is going to be largely inaccurate for individuals that have an injury. So what we need to do is create an equation that would better estimate the energy needs for those that do have an injury. So they did a study, and they evaluated tetraplegics versus paraplegics, and they tried to determine their basal metabolic rate and their estimated total daily energy expenditure. They did this by taking the equation that they would use for a non-injured individual and making a correctional factor. They used the factor of 1.15 compared to 1.2 for an able-bodied participant. And this next slide basically just shows you the math that they used. So just on one end, we have the equation for individuals without injury. And as you can see there, they put BMR times 1.2 for that correctional factor. And then on the other side, they just show how they derived the equation for an individual with an injury. And there they have the correctional factor of 1.15. Basically, they looked at METs, which is the metabolic equivalent of sitting still, which is equal to 1. And they adapted that to compare what that would be for an individual with a spinal cord injury versus without a spinal cord injury, and came up with this correctional factor. And so the purpose of their study was to determine, does this correctional factor more accurately predict the basal metabolic rate and the total daily energy expenditure for an individual with an SCI. So they found that BMR and total daily energy expenditure for paraplegics was significantly greater than those for tetraplegics. And it's not difficult to understand why that would be the case. Obviously, if you have the ability to move your upper limbs more and versus those that cannot move their upper limbs or their lower limbs at all, you would be putting out more energy, burning more energy. But the main thing that was really remarkable from this study was that the difference between the recommended caloric intake for those that do have an SCI versus if you just plugged in their information into the equation without the correctional factor, it would theoretically result in a weight gain of 7 pounds per year, because the non-corrected formula was overestimating their needs by that much. And you can tell that that would have a dramatic effect on their health. It would weight every year. It would put them at an increased risk for diseases, metabolic syndromes. It would be pretty devastating overall to their health if they were to theoretically gain that extra 7 pounds per year. So another research study developed these guidelines that would try to predict or try to give us an energy estimate for kilograms per body weight, how many calories they should consume per kilogram. And they found that a paraplegic should consume about 28 calories per kilogram, whereas a tetraplegic should consume about 23 calories per kilogram. And to put this in reference, a healthy adult without an injury should require anywhere from 26 to up to 39 calories per kilogram. So you can see there's a very big discrepancy in how much they should be consuming. And again, that if we are not giving them accurate guidelines and nutritional recommendations, this could have devastating consequences on their health because they'd be consuming too much. So other factors that you should be considering when giving nutritional guidelines to these individuals is that there are other factors that are determining their BMR at this point. Time since injury, level of injury, and completeness of injury. Studies have reported that there's a significant difference in the level of injury, with tetraplegics, as we stated before, having a significantly lower BMR than paraplegics. Completeness of injury also goes hand in hand with that, whereas those with complete injuries have a lower BMR. There have been varying results in the studies on the timing of the injury, with some showing that there's some adaptations with chronic injury. So the jury is still out on that one, and how we should best guide that. But that is an area for more study. But more importantly, to get back to clinical relevance, first, before we can give any type of advice to patients, we first need to define obesity for these individuals, because the definition of obesity is going to change. We can't use the regular parameters that we would use with somebody that does not have a spinal cord injury. And for any of this to be clinically relevant, we have to decide at what point are they at a body weight that is unhealthy for them. At what point do we define obesity for these individuals and say that they're at a higher risk for these type of metabolic syndromes. So the most accurate way to determine obesity, especially in an SCI population, would be the total percent body fat. The American Society of Exercise Physiology determined obesity to be at a body fat of greater than 22% in males and 35% in women. This is very difficult to accurately measure. It requires usually trained individuals, testing. And of course, as we know, we use surrogates in our everyday medical practice, such as BMI and waist circumference. And these in non-injured individuals have research-backed cutoff values that we know, at this BMI level, this is what we would determine obesity to be, and so forth. But there are no cutoff levels determined yet for individuals for these surrogate measures. So why do these measures not work so well? Waist circumference can be inaccurate due to varying degrees of abdominal paralysis with varying levels of injury. BMI understates obesity in people with this SCI due to the reduction of fat-free mass, and this is due to the sarcopenia, osteopenia, reduced total body water. So basically, these are not good surrogates to use for these individuals. So to help kind of determine a good cutoff score for obesity, they did a study with DEXA to compare body composition. They found that for every BMI level, individuals that had an injury, whether it be paraplegia, tetraplegia, so forth, had a greater proportion of body fat and less lean body mass than non-disabled controls. So for BMI 20, that individual that was a BMI 20 with a spinal cord injury had more body fat and less lean body mass than an individual without an injury that also had a BMI 20. And this just kind of goes back to the point that BMI is not a great indicator. Frankly, even in a non-injured individual, it's not a great indicator. But in 2018, researchers coined this term called neurogenic obesity. And to read out their very long kind of medical termed definition, they said that this was characterized by sarcopenic obesity, so basically due to muscle atrophy, as well as paralysis-induced neurogenic osteoporosis, loss of neurotropic influence, anabolic deficiency, sympathetic dysfunction, and blunted satiety that would profoundly reduces their whole body energy expenditure. And basically, they're just saying that there are all of these things that these factors that we've already talked about are all contributing to a decreased energy output by these individuals. So, and just to wrap up, that is still in the works, is defining a better way to define obesity in these individuals. So far, the best measure we have is the body fat percentage, using the 22% body fat and the 35% body fat for males and females respectively. So we're still researching on how to make a better surrogate measure for that. But right now, that's the best one that we have. And this is a very broad topic of physical activity and nutrition, but just to give some research-backed overall arching guidelines that have been found to be pretty good with the research. One particular study I thought really succinctly kind of gave it a good recommendation of 12. It was a 12-week study of SCI patients, and they completed regular resistance training in combination with a USDA diet. So this diet was a 45% carb, 30% fat, and 25% protein. They followed an exercise protocol that was designed to provoke muscle hypertrophy, so resistance training, weightlifting, in conjunction with the standardized diet. And they found improved lipid profile, lipoprotein, apolipoprotein profiles. They had an increase in their good cholesterol and a decrease in their triglycerides. This was a great study that just kind of really demonstrated the importance of both exercise that promoted muscle hypertrophy, as well as this diet that was on the lower end of carbohydrates and the lower end of fats. So again, these nutritional guidelines supported that the 45% carbohydrate diet, because their muscle atrophy that naturally happens with some of these injuries, is reducing the storage site for carbs. So we're going to end up with higher levels of plasma glucose, which would increase the risk for diabetes. They also did point out that we want to make sure they're having adequate fluid and fiber intake. This would obviously reduce constipation and minimize the needs for bowel medications, but it's an important part of nutrition, and it's something I think we do a really good job of emphasizing here. And then protein, at least 1.2 grams per kilogram for individuals, especially those that have had ulcers that need to promote healing, and even more so for those that have advanced injuries. And then a maximum of 30% daily intake from fats, 10% from saturated, and this is to reduce the risk of inflammatory disease and adipose storage. So bringing this all back to kind of our clinical application, obesity, it plays a role in many health complications, and this is true for both those with and without spinal cord injury. With those that do have spinal cord injury, we have the additional risk of making mobility increasingly more difficult, which can lead to many complications, being loss of independence, and increase of metabolic syndromes. And it increases them at a greater risk for cardiovascular disease, dyslipidemias, nutritional deficiencies, and delayed healing. And so overall, we truly need an individualized approach to determine the energy needs for individuals after SCI, whether this be in the acute or subacute setting. I would recommend that those individuals have close follow-up with a nutritionist after discharge from either their acute or their subacute hospital setting. I know we do a great job of having clinical nutrition on board here with us while our residents are here with us. But I think an individualized approach is really going to be what helps these individuals. But until we can have a better system for figuring out exactly what each individual needs, and until that becomes a more reasonable thing to pursue, as right now it's obviously not reasonable to have every patient undergo extensive lab testing to determine exact needs. I think these guidelines are a good starting place that we've discussed here. I think they're giving us an overarching guideline, but at least it's something that's a little more accurate than just your typical nutritional guidelines to go off of, and help these individuals stay free from disease for as long as possible. So thank you. We're excited. So if anybody has any questions.
What questions does everyone have? It's a great talk.
Thank you.
Excellent overview.
Thanks.
Open it up to the residents. Any therapists? Nora, any questions? And this is a good question. I don't know if Mackie will know because she's been primarily inpatient. Does anyone know the kind of options for outpatient nutrition in the Penn system?
I did try to look into what kind of options were available, just as far as insurance and that sort of thing goes. It was a very brief look for me, but largely depends on what kind of insurance you have for what kind of coverage you'll be able to get for outpatient outpatient nutritionists. I did not, and one thing I'd be interested to look into, and I did not have the chance to, would be if there are any spinal cord injury specific nutritionists. I don't know if that's something that exists yet. It would be interesting to find out if anybody actually specializes in nutrition for individuals that are post injury.
I think the only place that you'd find that is at like a big spinal cord injury center. I don't know of anyone here, and it's actually very hard within the Penn system to get somebody to see a nutritionist. Some of the clinics have like hired nutritionists, like the GI clinic, but it's not something that you can just like refer someone to see a nutritionist. Sometimes through like PCP offices, or if there's like diabetes or something, you can get them in with a nutritionist, but it's actually pretty challenging to arrange, despite many of our patients, and like you said, frankly, probably all patients who have a spinal cord injury potentially benefiting from that.
Oh yeah, for sure.
Mackie, I have a question.
Yes.
It's a little bit, maybe just a little bit circumstantial to your specific topic, but it's about the formulas that we feed patients, either through JPEG or IV. Can you comment, because so many of our SCI patients end up on them or come in needing that. Can you comment on the nutritional components of those formulas and how they're generally thought of amongst professionals and caregivers?
I don't know the specific breakdown of all of the formulas. I do know that ones that are higher in protein are preferred for individuals that have a lot of wound healing, and so that's something to consider. I know that we really push for high protein in those individuals, but beyond that, I'm not sure. That would be something I would be interested to find out from nutrition, exactly how they choose those.
Yeah, and it's very different in like the acute phase as opposed to the chronic phase, where you're having a lot of catabolism happening acutely after spinal cord injury and muscle loss. And weight loss in kind of the acute period versus the long period of time where, a lot of those supplements have pretty high calorie loads. And so it may not be recommended for each patient.
Yeah. Thank you.
Any other questions? All right. Well, Mackie, that's a great overview. Thank you so much. And we'll continue these moving forward. Thanks, Mackie.
All right. Thanks.
Thank you, Mackie. It was very informative.
Thank you.